not reading anything anyway, so I can look glazed eyes somewhere. So.
Also don't need to have your eyes closed the whole time, though, so if they are too
That's
bright,
right.
let me know.
There are doctors who speak that way. I knew a guy who, where I used to work, he was a GI doctor, and he would talk to his patients like this.
Really?
And we would joke that and he would do this like, not just blink, he would just like be like this.
That's so
And we would
strange.
joke that he was reading off of his eyelids.
That's really strange. Okay, so if I could just have you say your name so we have it on camera. That would be great.
Edward, Estes, and Sam Kim.
Okay, great. And your institution also that you work for. Or whatever.
It's one of those coughs that just decided it was going to come on.
Sorry, I don't have any water now.
No, I'll get my coffee in a sec.
Cups in here and no water, like that's helpful. Thank you.
No, it's fine. Yeah. So it's the Levine Cancer Institute, Levine, Carolinas Healthcare System, Charlotte, North Carolina.
Great. Okay. So your talk is going to be on future strategies and settings for immunotherapy in lung cancer. So what are you most excited about in that space right now? What are you hoping to kind of highlight in your chat?
The impact of immunotherapy in non-small cell lung cancer has been tremendous. The uptake, the interest by both providers and patients has been really, I think, unprecedented, and especially because of the wide applicability of their use. We now have second-line therapy, a single agent with 2 different immunotherapies, and what we're hoping for in the next year is to see if there will be expanded indications, most notably in the frontline setting. Now, there are multiple studies being done that are combining these immunotherapies with chemotherapy, with biologic therapy. And so where all of the dust settles next year is going to be very interesting. We're hopeful that there will be indications, multiple indications. I'm hopeful that there will be multiple combinations that will look promising and hopefully be approved. And of course, if we can find a biomarker directed population, that would be ideal. And so I think that's my biggest wish list for 2017.
So where are we at speaking of biomarkers with PD-1 testing, and how do you kind of see the role of that? Is it absolutely where it's going, or is there something else that might be?
Frankly, I've never really been a fan of a lot of expression markers. They can be helpful sometimes, but usually there's a gradient, and because you're picking a certain point on that gradient, you're going to see folks who have some expression, higher expression, and so how we define who that patient population is, I hope that whatever markers are indicated, if there are markers indicated, really show a distinct difference within populations. Maybe it will be a single marker, maybe it will be a combination of markers, maybe it will be a panel that exists. But I think there are a lot of people working on this question. My hope is that it's not too complicated or too cumbersome, because not only does that slow down getting the patient on therapy, but it also sometimes confuses our payers in that standpoint. And so equally important is physician and providers knowing the drug, patients being able to take the drug, identifying the appropriate patient, utilizing the appropriate marker, and making sure that there's no delay in payment for that therapy.
So you mentioned combinations. Are there particular combinations that are being tested right now that you're really interested in learning the results of?
Well, there are many, many combinations. We have multiple of these studies open at Levine Cancer Institute. I'm just curious. You know, it's not that I'm hoping one combination or another, or if it's a biologic combination. I have to say I'm probably more biased toward wanting to have non-cytotoxic regimens. This is why in the sort of spectrum of epidermal growth factor receptor mutations, it's been fantastic for patients who have that mutation. They can take a pill, and then when the drug stops working and their tumor begins to grow, more than half of them will have the opportunity for another pill. The fact that we can say that patients with stage 4 lung cancer could take oral biologic therapy for years is amazing, especially in the context of where we were in 2000, 2002. I hope that the same thing happens for immuno-oncology, that we're able to identify strategies that have lower side effects, that control the tumor just as well, and anything we can do to continue to displace more toxic therapies with less toxic, more tolerable therapies, I think is a win.
So do you see it kind of continuing to move up in the settings? I know we started out in slowly metastatic, and now it's gotten up in the second line. Do you see it eventually moving into first line? Or?
Yeah, I think currently we have approvals in second line. Next will be, hopefully, approvals in first line, and then there will be the first line sort of maintenance aspect. The combinations of drugs in the first line, whether they would be with other chemotherapies or other IOs or other non-IO biologic therapies. There will also be a sequencing question naturally if you have first line approvals and second line approvals. Can you give one first and another one second, or vice versa? There will naturally be questions of third line indication treatments as well. And maybe we will mimic the melanoma world where we are doing combination IO therapies. Maybe we will start looking at it more in the locally advanced setting with radiotherapy as a maintenance after treatment, definitive treatment. Everyone dreams about moving things to the resected, post-resection, post-curative treatment era, but as we know, based on a lot of studies we've done, it's a very difficult space to find an impact. But there is hope, and I think this strategy of trying to utilize your own body's defenses makes people a lot more confident that in fact these strategies may yield something more significant.
So as more of these become widely used, is there a learning curve for oncologists in using?
You know, I joke to my melanoma colleagues because they've had these drugs around for several years, both in melanoma and renal cell, and they were interesting drugs, and I think they transformed the care of patients with melanoma. But I joke to them, once these drugs got approved for lung cancer, now they're really big-time drugs because the lung cancer population is just enormous out there. And in the past, where many general oncologists may not have utilized these drugs because they weren't seeing those metastatic melanoma patients or renal cell patients, they're going to see these second-line lung cancer patients. And so there is a little bit of a trepidation whenever you use a new therapy. It's funny, we're more conditioned to treat neutropenic fever and sepsis and neuropathy than we are some of these endocrine abnormalities that occur or these immune-related side effects. And so there is a learning curve, but I think what people can feel very confident about are people like Jimmy Carter, who have metastatic melanoma and are being treated with an immunotherapy, and he's in his 90s and doing very well. So that's a good example of how tolerable these drugs are and how you can treat many different patients.
Is it difficult, now that there's a couple different agents out that are similar with Pembro and Evo, kind of choosing which agents, or is it all kind of the same too?
Right now, with multiple choices, they are not equal in the fact that how they're indicated. One requires expression of a marker and another one does not. So I think right now many physicians will take the path of least resistance. I like having choices. I like having more the merrier. This is America. This is where we should have competition. The better drugs should rise to the top. And so I hope we have 4 or 5 choices in this space and that the data is what will push us through.
So you're saying that having the marker is a little bit more cumbersome for some oncologists because the PD-1 isn't totally definitive at this point?
Medicine is very complex, and the practice of medicine is becoming more challenging these days. Providers are seeing more patients, they're getting less time to see these patients, and they're being paid less to see these patients. Any extra steps that are inserted in a clinic flow, a treatment flow, If there's any questions of reimbursement, these are all resources that many practices just don't have the capacity to spend lots of time with. And so anything that is simpler, easier, and equally effective is going to be better. I don't know why somebody's trying to open the door. So. Okay. Yeah.
I do have some at 9:45. It's only 9:32, so
Yeah.
I need to leave.
Exactly.
Okay, and then just I guess like a final overall question: what do you see on the horizon? What's next?
What's next? Boy, you know, if I look into my crystal ball, there's a lot of genomic testing going on, both commercially as well as within research. I think we all idealize the day where we would be able to send a tissue, a blood, a urine, a saliva sample, get a large output of data, give it to a bioinformatician or a program, and have Watson tell you exactly what drug you should be taking and what your risks are and whether you should lose some weight or bring down your blood pressure. I think we're still pretty far away from that. And I also don't like being told by computer programs or other things what is best. I always think there has to be a human element associated with it. That's why we have medical doctors and professionals who have trained for years to study and analyze each individual patient. And so I think it will be complementary. I think we will have a setting where we're getting rapid tests back, empowering physicians and providers to make better decisions on what may be a more optimal therapy for a patient, assessing risk, better whether you're higher or lower. But I think it's still a work in progress. But I think that's what we strive for.
Okay, great. That's all I have.
Right. Very good. All right.